Right. Next up, we have Mette Høybye, coming from Denmark. Mette is a professor at the Interacting Mind Center at the University of Aarhus and at Silkeborg Regional Hospital in Denmark. She works at the intersection of anthropology and clinical medicine. She's conducted extensive anthropological fieldwork in hospital settings and is leading ethnographic research tracing uncertainties of prognostics of consciousness in unresponsive patients with serious brain injury. She has a keen interest in developing methodologies of medical anthropology, currently exploring the body as a key source of knowledge in ethnographic practice and developing ways to work with this knowledge through creative movement practices. Thank you, Mette.
Thank you very much, Mette. And as you can hear, Mette is kind of a general term for women out of Denmark. So first of all, thank you, Mette, and the Oxford Uehiro Center for this kind invitation to speak here. And this is a really exciting conference, bringing together, I think, very ambitiously all these different perspectives on consciousness. So it's really an honor and a pleasure to share some of the work I've been doing with postdocs and research assistants in my interdisciplinary group called Borderlands of Living over the past years, research that has been funded by the Carlsberg Foundation. So the perspective that I'll be speaking from and bringing to this conversation here comes from medical anthropology and from ethnographic studies we've been doing into the signs and uncertainties of consciousness in people who have suffered severe injury to the brain due to out-of-hospital cardiac arrest or traumatic incidents or stroke. Coming really from this uncertainty that intensive care physicians have shared with us, that sometimes they wonder if it's life or death they're prolonging. So we've been exploring how signs of consciousness are produced in the intensive care setting to guide diagnostics and prognostics to support decision-making in these high-stake interactions around patients who are unresponsive between the clinical professionals and neuroscience researchers. And in this clinical borderlands, caring for unresponsive patients who have suffered an injury to the brain, and Alex has already now given you some insight into how this spans out. The signs of consciousness really serve to enact humanity in a persistent ethical dilemma of what makes a human and what makes a human life worth living. So maybe repeating a couple of the things that Alex has already explained. A severe acquired brain injury is characterized by unclear consciousness for an extended time following an incident with a near to complete absence of any intended movement or responses in the patient, and thereby a highly reduced agency. So this carries significant prognostic and ethical challenges for the clinicians working with and caring for these patients. Treating patients in a minimally conscious state move to a large extent around these practices and the use of the behavioral scales that Alex mentioned to seek to determine the potential for recovery of consciousness, producing concerns as the one I just shared about the boundaries of living. So clinically, these patients are categorized as either being in a state of unresponsive wakefulness syndrome, which was commonly referred to as a vegetative state by the clinicians we followed, or in a minimally conscious state. Both these categories that are more thoroughly explained here on the slide reflect an ambiguous state of consciousness that demarcates the uncertainty about a patient's potential for recovery. Such categories of the patient's state of consciousness is extremely difficult, partly because, as Alex already mentioned, it may fluctuate over time, and partly because the prognosis depends on several independent specificities relating to factors such as age, neuroplasticity, location of the brain damage, and origin of the injury. Still, these categories are really important for the clinical decision-making around the trajectory of the patient. So what we are aiming to understand in this research is how consciousness is an object of attention at the intersection of neuroscience research and neurocritical and the neurocritical care clinic, and what we might learn about the concept of consciousness by following the scientific and clinical practices that seek to establish evidence of consciousness. You've probably all come across sensational news stories about sudden awakenings by patients who have not shown signs of consciousness for years and who were diagnosed to be in a persistent disorder of consciousness. And you may also have come across the science side story to this, proposing a promise of neuroscience technology to enable new precisions in diagnostics and prognostics of consciousness, enabling basically better decision-making in the clinic about a patient's potential for recovery of consciousness and function to a certain degree. And the reason that the clinical eye is on consciousness, and now I should probably mention that what I refer to now as consciousness, and what I think also Alex's talk really exemplified, was that once you go into the clinic, no one actually speaks about consciousness. But still in interviews with clinicians, they will say that all the things we do, everything that we attend to here is about consciousness, about seeing if we can get a response, about seeing if the patient is really there. And this is also what one of the ICU physicians who was part of the research group planning the experimental fMRI study that we later were invited to follow expressed as the objective for what they were doing. He said, we're really keen to know if there's anything or anyone at all. Or what he actually said in Danish was, "Er der hul igennem?" Briefly translated, this directly means, is there a hole through? So, so this is what he's wondering at the bedside of the patient. And among neuro-intensive care professionals in charge of treating these unresponsive patients, it's a common perspective that the body must be given time for the brain to wake up and respond. And the clinical space, this is enabled by a continuously improved and advanced medical technology, which makes it possible to sustain life to a much farther degree than previously. But also, as you can imagine, this is a really inherently uncertain space where the physiological responses of patients are constantly assessed and weighed as to their potential as signs of consciousness, comparing and contrasting the sensory and behavioral signs with potential signs from neuroimaging, also mainly from MRI and EEG. So uncertainty is a basic condition of medicine in research and in the clinic and at the intersection between the two. And new advances in neuroscience technologies, such as the fMRI studies reporting to show a potential to communicate with patients, are proposing an answer to a certain degree to this uncertainty to make diagnostics more precise. But just to give you a tiny sense of what this space of uncertainty at the patient bedside is like, I'll invite you now to the bedside of Hannah, a neurointensive care unit at a university hospital in Denmark. And I don't know how many of you have been ever close to or seen a patient in a vegetative or minimally conscious state of being. But I hope this illustration of a completely common practice, as Alex has already described, using the Glasgow Coma scale to behaviorally assess, can give you a sense of the space of uncertainty that the neurosurgeon navigates as she seeks to assess Hannah's level of consciousness. And the illustration there is just one of the illustrations from the ward explaining about the consciousness scale or the coma scale. So Regge, the neurosurgeon, observes Hannah, who's the patient, closely. She takes Hannah's right hand and asks her to squeeze her hand. Nothing happens. There's no response. She puts the hand down and tells Hannah that she'll be examining her eyes now. All movements are slow and there is quiet in the room, except for the mechanical ventilator humming. Regge's voice is calm and low. She gently touches Hannah's eyelids, one eye first, then the other, while she says, "Try opening your eyes for me." Nothing happens, and she returns to the eye she first touched and lifts up the eyelid to see the pupils. She shines a light in the eye, and the same procedure follows at the other eye. There's no immediate or visible response. So there's no independent agency available to these patients that we have any sensory attunement to in the clinic. They have no access to active social interaction, and they're very close to just being a body, being examined and acted on to assess their status. Their bodies are cut off from the functions and engagement that normally tie us to the world. A proportion of them may regain independent function to some degree, a large part will not. And for now, it's unclear who will and to what extent. And this is really the challenge that the experimental fMRI sought to suspend. So we got a chance in this research to follow the introduction of a new experimental fMRI protocol in Denmark on patients who had suffered an anoxic injury to the brain due to out-of-hospital cardiac arrest. And we build our work on extensive ethnographic fieldwork across different highly specialized sites, including clinical and research settings, employing a combination of participant observation and interviews. So the material I'm sharing here is from ethnographic participant observation at a highly specialized acute neuro-intensive care unit, where patients are immediately transferred following surgery from the emergency department, as well as from a different neuro-intensive step-down unit. And I'll invite you along on one of these experimental fMRI scans to exemplify this search for consciousness and the struggle for prognostic assurance. So after a number of behavioral tests have been carried out at the ICU, the patient is moved. And moving the patient, as you can see from the large crew following the patient transport here, this is not a trivial endeavor. And this is the scanner. The patient will be in the scanner for approximately an hour and 15 minutes, undergoing numerous scanning sequences, and among these, passive musical paradigm. And a great number of people were involved, calibrating the scanner, testing the paradigm, adjusting, just taking notes, and looking after the patient. So as the images start to emerge on the screen, and I'll just say that we didn't take any photos of the actual patient scans for ethical reasons, as they were not able to consent to this. So the scan you see on the screen here is my brain. But as these images start to emerge, activity slows and everyone's attention turns to the screens. At certain points, almost feels like everyone in the room are breathing like one organism, watching the patient in the scanner. One of the things that you'll notice through the window facing the scanner is that there's a specialist intensive care nurse beside the patient in the room, ready to ventilate the patient by hand if need be. And you would watch the patient in the scanner, not necessarily lying still as required and expected during an fMRI scan, but possibly doing sudden or subtle movements caused by the patient's panted breathing or sudden reactions to the whole situation. In this space, we observed with the neuro researchers, with the clinicians, and had conversations with them along the way about what they saw and how they understood what they saw. So what's immediately clear is that this is a space of uncertainty, and several new uncertainties are produced by the experiments. What you see here is a very limited excerpt from field notes during the experimental fMRI scan of a patient with anoxic brain injury after cardiac arrest. So one of the persons in the room, one of the researchers sitting in front of the screen, is getting increasingly frustrated by the difficult context of the scan, the analytical challenges and the uncertainties that this type of patient introduces. And he says, the images look like crap. Even the most creative analysis won't tell if that was a response or if he just moved. On the other hand, there's the ICU physician in charge of treating this patient who is more confident with the situation and really pointing to the power and the potential of the neuroimages as evidence that can be used in conversation with relatives. So she says, in particular, if you're moving towards ending treatment, then we can say, we observe this, and now we also have these images to tell us this. But again, she stresses, with this specific patient, she won't expect to use the fMRI for anything, as they don't have much doubt that he's vegetative. But to everyone's surprise, when they ran the analysis of the images from the fMRI, they did see a response. And this brings life to new uncertainties. The researchers were excited that there was a response and the experiment was to some degree successful. But how would this be used? How could it be translated? Which impact would it have in the clinic? And as you see here, I went over with one of the researchers to share the results with the clinic, and he's relaying the results to the intensive care staff, and he's excited, saying over and over, we actually found something, we can actually see something. And we were all standing in a small circle around him with the printout of the analysis, and he is very careful to stress that this doesn't say anything about consciousness, it only means that there is a response. But this brings life to new uncertainties. The researchers were excited, but the clinicians were close to horrified. This gives me the chills, they said. This is a bit alarming. This is frightening. They had a sense of uncertainty reinstalled, really worried that they had been overlooking signs and cues of consciousness from the patient. What would they tell the relatives now? Should they actually reevaluate their decision to withdraw treatment? So what we see here is that there is a long way from the promise of a potential of neuroimaging to provide evidence of consciousness in these patients, and a huge number of ethical dilemmas attached to a future translation of responses into clinical practice as a prognostic tool. And the uncertainty does not go away with the neuroimage. So how does the evidence of an fMRI response map onto the experience of clinicians and relatives at the bedside of the patient? The ones who are the only ones accessible for interpreting what they see and what the patient may actually be experiencing. They are constantly weighing and interpreting the sensory and behavioral signs of consciousness, as we saw at the bedside of Hannah. The nurses, the physio and occupational therapists we followed through their practice and care routines with these patients speak of islands of consciousness, pointing to consciousness in these patients as fluctuating, and their experiences of interacting with these patients over time that may produce responses that they then interpret as signs of consciousness in small glimpses, and then possibly stop showing these identifiable signs. The clinicians would talk about the patient as showing herself to them. This extensive ambiguity as to what the patient would be able to show and how it might speak to a potential for a life worth living was a constant uncertainty in the clinical encounters. And while small signs might be seen as clinical improvements, moving the patient positively along a perceived spectrum of consciousness, it was also widely recognized, as one of the physicians shared in a conversation, that it's really only in here that it's celebrated that you're able to move a toe. So agency and capacity does not necessarily follow. And what's identified as a potential for recovery of consciousness and rehabilitation in the clinical setting is dependent on which signs count as relevant. And several contextual factors play into this assessment. These often take the social context of the individual patient into consideration. What would be the best possible life for this patient? Would anybody be around to support her? We see with this a need to emphasize the moral aspects of claims about potentiality, as well as the productivity of the ambiguity involved when dealing with that which does not yet and may never exist, as Taussig-Hoyer and Helmerich has stressed it. What everyone is hoping for and working towards in the clinic is that such islands of consciousness should give way for more solid land, to stay with that metaphor, and that the signs of consciousness will stabilize and move the patient towards a sense of possibility and potential for life. The analytical attention in this work is on how signs are made to count as signs of consciousness, which adds to a wider interdisciplinary discussion of the moral landscapes of clinical and experimental borderlands. By addressing the connection between the concept of potentiality and the assessment happening in the clinical and neuroimaging practices, we want to show how the concept of consciousness and the biomedical idea of what makes a life is steeped in the rationale of the functional human. But what is also very apparent is the contextual process of interpretation of science and the social life of science of consciousness, looking at the complex social and structural dynamics that are part of the interpretation and classification of consciousness, what we describe as an enactment of consciousness as a biosocial process. Assessing consciousness is a social interaction centering around the patient body, but which cannot include the patient actively, only to some extent by proxy of the relatives. And while I've not engaged with the concept of personhood in this talk, which may seem odd, but would have taken us down another analytical path in our research, I'll just give a small example of how the personhood of a patient with severe brain injury is constantly sustained in the social interaction between professionals and relatives, despite the possible lack of signs of consciousness. And you'll probably need to stay a bit still to listen to this. But what you're seeing and hearing here is a curious sample of the Spotify playlist and the vital measures of a young man who was struck by a car walking home from a party. His parents and the professionals caring for him agreed to let the music play to form a potential bridge for the young man in the bed to the young man prior to his traumatic incident. And you can hardly hear the music. Apologies for that. It sounded really loud on my computer. But this is just really an example of practices playing out in the clinic, trying to form these connections to patients, trying to help patients call out somehow to their previous experiences of the person they used to be. Such interactions delineates a negotiation of signs at the bedside and how the bodily movement of the patient aligns with expected and known progressions. A negotiation where the patient of this young man would be a negotiation where the parents of this young man would be keenly watching and assessing any glimpses or movement or twitches that he might have, signs that if they occurred, they would bring to the immediate attention of the professionals as evidence that he was still here. In this way, there's a continuous intertwinement of personhood with the search for signs of consciousness. So signs of consciousness imply a process of biosocial sense-making in these patients, carried out as clinical practices and sensory attention around the patient body. The diagnostics and prognostics of consciousness is carried out in a complex context of the clinical assessment of signs and valuations of life worth, in close dialogue, obviously, with the relatives. A response and brain pattern potentially detected by neuroimaging technology does not dissolve the ethical dilemma of interpreting how such signs are made to count or not. And the uncertainty even extends, as we have seen with the technology. This often has the consequence that wait and see really becomes the most viable option in clinical practice. There may not be any clear signs towards progression of consciousness, but at the same time, the signs of the opposite are also not clear. So neurocritical care is a space of uncertainty, I think you'll agree, where the healthcare professionals fight for the survival of the patient and the best possible outcome. This is their professional pledge and the structural and political context of care. The indicators for decision-making, the signifiers of potential or decline of consciousness as points of orientation, are not stable in this process, regardless of the neuroimaging. And as one of these ICU physicians shared with us, you just have to have a great amount of humility towards the potential outcome. Some say, why don't you just end it here? And we just have to say, we don't know where it ends, what they may be capable of. So we have been investigating negotiations of evidence in the experimental engagement of neuroscience in neurocritical care as an enactment of signs of consciousness. And by this, I mean that our analytical focus have been moving through the practice of both neuroscience research and neurocritical care to understand how ideas and evidence of consciousness are shaped in and by practice and negotiate what comes to count as consciousness. So the power and the promise of neuroimaging in vegetative or minimally conscious patients to suggest a promise to counter the uncertainties of consciousness. And the translational encounters of neuroscience and neurocritical care are imbued with uncertainties and ethical dilemmas. The neuroimaging technologies are embedded in complex contexts of clinical decision-making, contextualizing them with behavioral science and social considerations of the individual patient. And the response and brain pattern potentially detected by the technology does not dissolve the ethical dilemma of interpreting how signs are made to count or not. So consciousness may at the same time be perceived as essential for the sentient being and only one of several intertwined decisive dimensions in relating to patients with severe acquired brain injury. Thank you.